Hi, this is Kelly Bergman, and today I'm going to talk about point-of-care ultrasound for intussusception. Most children who present with intussusception are 6 months to 6 years old. Children usually present with fussiness, vomiting, and bloody stool. At least that's what's taught as the classic triad. Most children do present with abdominal pain, about 80%, and about 60% with vomiting, but bloody stool actually isn't that common. Only about 20% of kids will present with that. On the right, you can see data from a large study that we conducted. A linear high-frequency probe is best and will allow you to really visualize the bowel well and show more superficial structures. And just a quick note about the footprint. If you use more of a small footprint, you can get more kind of tunnel vision, and you just have a small cross-section that you're cutting through compared to a wider footprint that gives you a little bit bigger cross-section to visualize through. You can use a curvilinear probe if you have a more obese child and you're having trouble visualizing structures deeper than 4 or 5 centimeters. But in the vast majority of kids, a linear high-frequency probe would be the ideal choice. You want to start in the right lower quadrant. People talk about an upside-down U or the lawnmower.
You can find my psoas muscle by placing the probe over my right lower quadrant. Slow and gentle pressure will move gas out of the way. This does not hurt at all. If you are not sure, throw some color Doppler on the screen. The artery is easy to find right next to the psoas.
With the upside-down U, you're really tracing the colon from the ascending colon to the transverse colon and down to the descending colon. The lawnmower is just starting in the right lower quadrant and scanning up and down throughout. I think either approach is okay, but with the upside-down U, you may miss some intussusceptions that are in the mid-abdomen. And those tend to be more small bowel to small bowel or ileo-ileal intussusceptions. So personally, I recommend starting in the right lower quadrant, tracing up the ascending colon and going over to the transverse colon to the start of the descending colon. And then I go and do a lawnmower approach from there, scanning throughout the mid-abdomen. So here are some normal findings. What you're seeing is just normal bowel peristalsis, normal bowel gas, nothing that's clearly showing a target sign. On the image on the right, you can even see the part of the liver at the start of that clip and the gallbladder as well. So you see you're in the right upper quadrant there. Just some other clips showing normal findings. So we've all seen the target sign on ultrasound, which is shown here on the left side. This is essentially a cross-section of an intussusception, where you can see the entering segment or the intussusceptum going into the receiving segment or the intussuscepiens. And then on the right is more of a normal comparison. Here's another example of an ileocolic intussusception. You can see clearly the target sign in the folds of bowel on the left hand clip. Third example of an ileocolic intussusception. You can see the sonologist kind of flips their probe. That's a great example of an intussusception. So typically, ileocolic intussusceptions will measure greater than 2 or 2.5 centimeters The exact number is a little bit variable in the literature, but that's a general number you want to keep in your head is about 2 centimeters. So here you can see examples where the intussusception measures 3.6 centimeters or 3.8. Those are ileocolic intussusceptions. In contrast, ileo-ileal or small bowel to small bowel intussusceptions measure less than 2 centimeters. So here on the picture on the left, you can use the scale to see that that is just about 1.5 centimeters. And then the one on the right is measured at 1.89 centimeters. Those are more consistent with ileo-ileal or small bowel to small bowel intussusceptions. So here's an example of an ileo-ileal intussusception. On the left, clearly you can see kind of folds of bowel, and you definitely see more of a target sign. Another example of an ileo-ileal intussusception where the sonologist flips on their probe to show a transverse view as well. Some findings to look for when you're doing this scan include trapped free fluid. In this clip, you can clearly see that there's some free fluid. So this is important because this can help you predict who may be more likely to have a difficult reduction by enema. Just another example of trapped free fluid. You can also see decreased Doppler flow, which also is indicative of failed enema reduction. So here's an example of what might be more normal Doppler flow. So in contrast, here's what diminished or decreased Doppler flow would look like. Now we'll go through a few pearls and pitfalls when doing this scan. Some tips or pearls would be to make sure you're scanning the entire abdomen, including the small bowel. You can use the bladder as a window, so starting in the midline in the lower abdomen and scanning or fanning to the right to look at that right lower quadrant can sometimes help if bowel gas is interfering. Using graded compression can also help to get bowel gas out of the way. And being patient, even though it's a pretty easy scan, what I mean is even sitting there for a couple of minutes can make a difference in terms of being able to get good views. So intussusception versus stool. Here you can see an intussusception on the left. On the right, you see these really kind of hyperechoic features within bowel. That is what stool typically appears as. Clearly different, but sometimes that can be mistaken. Inadequate depth. Here you can see that you can't really identify the bottom of the intussusception. It's a great example of an intussusception, but the sonologist is looking only 2.5 centimeters deep, so they can't fully see how big it is.
So here's an example of the opposite, actually, of using too much depth and how that can lead to inability to reliably identify an intussusception. So on the left, the user had used a depth of over 9
centimeters.
On the left, they use a curvilinear probe, which you might be able to use in a patient with bigger body habitus if you're not getting enough visualization into lower tissues, but really this highlights why a linear probe is preferred.
Stop, look, and listen. This is a mess down here, and there's more going on than a target sign. Could this be a ruptured appendix? Clinical correlation is advised.
And just to close with a case, so you have a 2-year-old male that presents with fussiness, inconsolability for about 12 hours. They've vomited a few times and don't have bloody stool. Their last stool was this morning, and the parents say they think it was normal. And the patients had low-grade temperatures of around 99. On exam, the patient's fussy, really hard to examine. The abdominal exam is just tense because the child is just crying the whole time. So it's hard to get a sense of the abdominal exam. There's adequate perfusion, and you do a bedside ultrasound, and this is what you find. The target sign is essentially a cross-section of an intussusception. The target sign measures 3.6 centimeters in diameter. So naturally, you call radiology and arrange for pneumatic reduction by enema, and the case ends well. So in summary, scanning for intussusception is fairly quick and easy. You can expedite and inform your care by communicating with radiology in a more prompt manner. This can guide your decision to obtain IV access or labs. It can inform parental guidance as well in your conversations with parents. I find that really useful in just explaining what an intussusception is. During the exam, just some things to remember are be patient, sit there for an extra minute or so to make sure you're getting good images. Make sure you're looking at the right lower quadrant, tracing the colon, and scanning the mid-abdomen for small bowel to small bowel intussusceptions. Make sure you're using appropriate depth, which would be about 4 to 5 centimeters. And if you do find an intussusception, measuring the size can be really helpful, in addition to looking for free fluid or decreased color Doppler.